Thank you, Linda, for the nice words. I appreciate it. All right. It's a pleasure being here. Thank you, Facial Pain Association, for inviting me. You're doing some wonderful, wonderful work, really helping access to care and uh, taking on numerous initiatives. So the field is appreciative of what you do. I do not have any disclosures. So all right, so we'll talk about orofacial pain, some basics. We'll talk about diagnosis, clinical case. We'll discuss a couple of cases, and we'll kind of dive into diagnosis and treatment. All right. So before I start, I think this is a great uh, introduction to kind of chronic pain, which is very different than dental pain or acute pain. And Karen Davis for International Association of Study of Pain did this video several years, and people who've seen me have seen this lecture because I think it helps. I'm going to skip
Dr. Chandwani, we are not able to hear the audio for this.
Oh, you're not? Okay.
No.
Let's see. I apologize that. So this is a video on how your brain responds to pain. I hope now you can hear the video.
There is still no audio, unfortunately.
All right. I'm going to skip the video. I'm sorry for technical issues. I'm happy to share these slides, and you could kind of look at this video on your time because it gives you a really good understanding of why chronic pain is very different than acute pain and how different people react very differently to multiple stimulus. And that's extremely important in facial pain population or any chronic pain population. So uh, that's a good way to kind of introduce you all to the field of orofacial pain, which is a new specialty recognized last year by the American Dental Association. I'm lucky to be a specialist because of my board certification and training. And orofacial pain training involves a fair bit of medicine, a little bit of neurology, a little bit of psychology, which makes us prepared for a kind of a complex scenario, and it's quite a bit different, and which is interesting as well as stimulating. It's interesting because, as you saw in the introduction video, about 10% of people, adult population, suffer from TMJ disorders. And if you include headaches, that number is a little higher. If you include chronic pain disorders, insomnia, now that number is quite a bit. So on any given day, if you're seeing 20 odd patients, there is a good chance you're seeing one or two of patients who are suffering from these conditions. So it makes it extremely important to be aware of these conditions. You'll be providing a much needed diagnosis as well as treatment in a lot of these conditions. So the orofacial pain is unique because it kind of goes from one of my mentors during my training used to say, we pay attention to the tooth and the person attached to the tooth. So that's a good summary. We paying attention to psychology, to sleep medicine, to the trigeminal system, as well as different muscles, different neck structures, nerves. So, and it really is beyond just the temporomandibular joint. In this, it all started with the temporomandibular joint, but the field is much more involved. And I really like to think of it's more the brain than the trigeminal nerve or the dental structures when it comes to orofacial pain. It often starts with the trigeminal nerve or the odontogenic issue or pathology at times. This is a good schematic of kind of putting different conditions in a classification algorithm. And it splits into unilateral continuous pain versus unilateral episodic pain. And it talks about kind of mechanism for the most part, going from neuralgias, it includes muscle pain, persistent orofacial muscle pain, burning mouth syndrome. And this sort of a classification is helpful because it gives you clues as to treatment strategies for each individual patients. So tailoring kind of the diagnosis as well as the treatment is important in these patients. These are quite common conditions, especially muscle pain being 60 to 80% of temporomandibular disorders, or orofacial pain tends to be muscle pain. And then the uncommon conditions tends to be neuropathic pain, even trigeminal neuralgia, which happens in like 0.3 to 0.5% of people. So it's important to know these conditions because you will, as a dentist, you will see them quite common. Unfortunately, most of these conditions, including muscle pain, the exact cause is not known. We really don't. We have some sort of understanding of the mechanism involved, but we really don't know why certain people suffer from this. I did my dental training in the 90s where back in India, a lot of these conditions were blamed on stress or psychological factors. But now that theory has evolved. Stress, psychological factors definitely play a strong role, but at the same time, it's not really the cause in a lot of these patients. I'm sure there's some patients where it's causing the problem, but for majority of patients, there's multiple variables, and then those variables can include nutrition, it could include morphology, it could include behaviors, it could include kind of medical comorbidities. Some patients have autoimmune disorders. It's a laundry list of possibilities. So, and that's probably why certain patients do tend to be a lot more severe, because they have more variables compared to some other patients who are not as severe. All right. Persistent idiopathic facial pain or atypical facial pain, it's a poorly understood kind of neuropathic pain conditions. It's essentially a disorder of the neurogenic component of the peripheral or central nervous system. So we really, for the most part, we think it's more the central nervous system rather than the peripheral nervous system. Although the pain location is in the periphery, typically it could be a tooth or it could be part of a tongue. So several possibilities. And International Headache Society has has classification criteria which you could use. They're kind of on the slides. And typically, there's a fair amount of correlation with psych disorder. So trigeminal neuralgia, which is classically a clinical disorder, it's diagnosed with its clinical features. I would say most people who've seen trigeminal neuralgia can diagnose it like this, because it's got this presentation of short electric-like. I had a patient day before yesterday. She's like, I feel as if a drill is kind of cutting into my bone. The pain is so deep, and so if you use patients' words, it's always a little bit different, but it's really stands out. Often at times, patients will say this is the worst kind of pain they've ever felt in their life, and not one patient. In my short career, I've seen a number of patients who say, oh, this is kind of, I cannot imagine anything worse than this. And it's quite debilitating. Patients get disabled from this pain, especially with increased frequency. It's almost always evoked. And when I say almost always, I'm talking about idiopathic trigeminal neuralgia, which is due to no known reason. Secondary trigeminal neuralgia or trigeminal neuralgia related to intracranial pathology may be more spontaneous. And typically, it lasts for fractions of a second to like 2 minutes. The new definition does talk about a lingering pain in between attacks. So a patient can have almost constant pain with these electric shock-like intermittent jabs. Most of the times it's limited to one division of the trigeminal nerve, but at times it may go to a second division, but it always follows a nerve. So if a patient comes in where the pain is not limited to like a pattern, but it's electric shock like, it has to be diagnosed as neuropathic pain. And that's very important because 60 to 70% of trigeminal neuralgia patients do respond to kind of surgical interventions, while neuropathic pain, that number goes down to 30, close to placebo. So that's extremely important to have a diagnostic criteria to follow that. Anytime the pain does not follow a path, typically trigeminal neuralgia, you'll see trigger zones. It's almost always evoked, and some people may, classically, it's cold water, cold air on the face, which triggers the pain. Some people, it gets triggered with brushing, swallowing, shaving, rubbing a towel on the face. So, but there's definitely variations to that. Okay. And this is where the dentist role comes really important. So over the years, 40%, about 40% of trigeminal neuralgia patients undergo dental treatment, and resulting in sometimes worsening of symptoms. So unnecessary dental procedures as a consequence of trigeminal neuralgia is a big problem. This study, they found 48%. There's another study which found about 27% of trigeminal neuralgia patients had unnecessary dental procedures. So that is unfortunate. And at the same time, because trigeminal neuralgia, there's no clear diagnostic test. So it's really the clinical exam and clinical symptoms that determine the presence of this. Often at times, patients are frustrated. And then, of course, at times, dentists can be frustrated too. We as dentists, we want to help the patients by doing the right thing, or at least providing some sort of a treatment. But at the same time, it's important to know if it does not sound like a typical odontogenic pathology, including an objective test. It's better to kind of get a second set of eyes, and it could be a neurologist, it could be an oral surgeon, it could be orofacial pain. There are options to have a second opinion. So this study in OOE looked at ineffective or unnecessary dental treatments with neuropathic pain, and they found 36% of patients. It's a small study, it's not a large study, but around 50 odd patients, but it's still a significant number of people who get these unnecessary procedures, and often with not great results. 20% of headache patients had dental procedures in headache and jaw pain. So this is really orofacial pain patients who had dental treatment, not classic headache patients. 1 in 5. So that's a big number. So it's important to kind of, again, recognize this. 26 patients, again, same message. And this is a recent study. Don Nixdorf has done some wonderful research at University of Minnesota. 1 in 4 people, that's a lot of numbers. And I don't think I have that another study where they found that 10%, 8 to 10% of patients who undergo endodontic treatment at 6 months post-op tend to have persistent facial pain. So, or persistent pain in that tooth. And that number goes down around a year. So that's important to, again, think of if a patient undergoes a dental treatment, be it a filling or root canal treatment, or even an extraction, and they come back and they have some persistent pain and there's no objective sign, giving it more time, and unfortunately a lot more time, 6 to 12 months, rather than doing another procedure, may be what we need to do. So why is that? Why do some patients have these pain despite, so some people definitely have pain, which is neuropathic pain, trigeminal neuralgia, where they get dental procedures and they get worse. But there's another set of patients where they could have neuropathic pain or trigeminal neuralgia, and they need a filling. They have a decayed tooth or a root canal, and now they get worse. Why does that happen? Because with trigeminal neuralgia, even though the trigeminal nucleus is in the brainstem, the pain mechanism involves brainstem and part of the brain. So if you look at trigeminal neuralgia patients, often at times, at some point, very quickly in the condition, it involves the cortex. While if you look at other pain conditions, be it muscle pain or neuropathic pain, it involves thalamus in addition to the brainstem. So there's distinction. So often at times, if a patient has a sleep disorder, in addition to neuropathic pain, it's because the thalamus is involved. So we're getting to know more and more about these conditions, which is helping us better treat these patients as well as better diagnose these patients. So switching gears, I know I'm going a little fast because there's a bunch of questions already, so I want to get to the questions soon. So 76-year-old male presents, this is a patient I saw about 2 months ago, sharp stabbing pain in the lower right since a few weeks. It's mostly there when I touch the cheek. Moving the jaw hurts, but not as bad. Location of the pain is intraoral over the alveolar ridge on the right. Has a history of implants, and it just started. Okay. So he had an interesting medical history, polio in his childhood. Currently, he's not working. He's on opioids, as you could see, some opioids, and he's reduced the dose of the opioids. So I found that was interesting. So if you look at his history, he went down on his morphine in the last 3 months, and he really started having pain in the last few weeks. So I think that's it's playing a big role in this condition. So he fit the criteria of neuropathic pain. In his case, did a workup overall. This, apart from clinical signs and symptoms, there's nothing else stood out. We actually decided to wait on to no treatment. I gave him some palliative treatments, asked him to do some zinc supplements, which can help neuropathic pain. And after about 2-3 weeks, he got a little better. Okay. So, and you don't have to treat trigeminal neuralgia, but of course, at times you may want to treat it. So always stay in your comfort zone. Again, a disclosure, I do have residency training in orofacial pain, so I will talk about treatment. If you're uncomfortable, reach out to a colleague or reach out to, happy to answer your calls. But don't overtreat it or don't go out of your comfort zone. Okay, so so I diagnosed him with trigeminal neuralgia. Sorry, I said neuropathic pain. It's really limited to V3. Offered him topical benzocaine. I asked him to do 3 times a day over kind of the trigger zone. And he did it very sporadically. Saw him about 3 to 4 weeks later. He's like, it's definitely getting better. I don't think it's a topical. I think it's just time which is making it better. So at times, especially with complex medical history, I often take a palliative route and wait and see how things go. Okay. So, I did tell him anytime you needed dental treatment, major dental procedures, I would advise to take gabapentin 1200 milligrams 2 hours prior, just to avoid any kind of flare-up of symptoms. Okay. So I'll switch gears to a different case. So 66-year-old female, left side facial pain, started about in 2017, and in 2017 she was given gabapentin. It had helped, pain alleviated completely for several years, and then last year it started again. She said she's unsure what triggered the pain. When I asked her if she's married, she said, yes, you have kids. She has a daughter. She's taking care of her grandkids. And things are a bit stressful in the house. She's running around. She is a retired accountant. She starts her day at 6 o'clock in the morning. So not emotionally draining, but physically very taxing schedule she's had in the last several months to a year. So she saw a neurologist in February 2023, so a few months before I saw her, who started on oxcarbazepine. And she was like, I did it for like 2 months. It had no benefit. She also tried some Chinese herbs, didn't help. Okay. These were, I often use patients' words. This is all, I find it's helpful to me. And this is what I mean. If it's trigeminal neuralgia, you know right by the history. It is sharp, hot, and so painful. I never know when it's going to come. And she started crying when she was describing this. The pain is like cutting, burning, so severe, like electric shock. It's so awful. So So this is kind of the patient, okay? So in her case, shouting, brushing, sneezing, chewing, sometimes bending the head down. A lot of times I can't make sense of why these trigger zones are present or how the mechanism works. And so the understanding is definitely still lacking on multiple fronts in this condition, even though we've known about this disease for hundreds of years now. She's busy, as we talked about, and I think it's playing some role. She does not drink alcohol. She drinks 1 tea per day. So she has a medical history of diabetes, cholesterol, hypertension. So this is kind of my workup again. So I did a history, clinical exam. She didn't have any nerve deficits. So I kind of told her, you have trigeminal neuralgia, and I think we should go back to gabapentin. Okay. So she was like, gabapentin, yes, it had helped me in 2017. I was like, yeah, that's why I want to go to gabapentin. Otherwise, oxcarbazepine is my first choice also in most of trigeminal neuralgia cases. Started her on gabapentin and saw her, let's see, oh, patient is, okay. I saw her after about 3 months, and she's like 1 month. So I saw her last month. So she's all of June, she said she's suffering. She was miserable. She was like first or second week of July, it was like an on-off switch. She was like, my pain level went down in frequency and intensity by like 60-70%. And just with gabapentin, no other kind of treatment. So in her case, it's really a top-down intervention, as you could see in this, my slide. Often at times, the previous patient was more a bottoms up, where I asked him to do some palliatives, topical medication. So depending on the patient, depending on the medical history, depending on the patient's suffering, you got to kind of pick a strategy. And she did great with that intervention. So next step is really another 3 months. I'll keep her on gabapentin and see if she continues to improve, where 28, 29, my goal is like 27, 28 days in a month, she has no pain. So that's kind of goal. If it's not enough, I may add another anti-epileptic or an antidepressant. So there's different modalities which can help. There's data about very limited data, but there's limited data for using topical medications. I'm a big believer in topical medications. They help. They don't have side effects. If you look at studies, the science is very limited. Again, the financial incentive is limited for those self-care supplements. Again, lot of options. Like Magic Johnson said, all kids need is a little help, little hope, and somebody who believes in them. That's a big showing empathy to these patients. That's my philosophy, and it should be everybody's philosophy. It's extremely important and extremely helpful. I took this from Practical Neurology. Dina Kuruvilla wrote this really good paper on headache. It was really on headache, but this really applies to neuropathic pain, trigeminal neuralgia, and there's certain modifications. If patients have nausea or kind of more autonomic symptoms, they feel a little dizzy, I always find magnesium and butterbur works better. If it's muscle pain or kind of they have more constant pain, they feel weak, I find zinc helps, magnesium helps. So again, try them. and you'll be pleasantly surprised how well a lot of complementary medicine works. I'm certified in acupuncture, so at times I do involve acupuncture, especially when patients have neck pain or poor sleep. So there's number of options. So going back to our patient, I started her on gabapentin 400 milligrams 2 to 3 times a day. I stopped her oxcarbazepine, and I told her I may do some topical medications or botulinum toxin or different medications. I usually write this down for patients. So she came back earlier this month and she was like, things are a lot better. Okay. And her words were, it zings sometimes, and it's really at the end of gabapentin. Even though we know gabapentin doesn't work as needed, I have a number of patients who tell me this, that as soon as 6 to 7 hours happen, they start having this pain. So I had asked her to be on like 1200. She found it was giving her side effects. So to conclude, the perception of orofacial pain, it's difficult. It's difficult because most objective tests are lacking. Okay. I had a patient who got into an accident, and this is on I-95, a major highway in the Northeast corridor, and she was dragged by an oil tanker. She was in a passenger seat, and she was dragged for almost a mile. The oil tanker, I don't know exactly how the accident happened. And I saw pictures of the car. It's completely demolished. Her boyfriend was in the hospital for like 25 days, multiple fractures. She did not get any fractures. She was bruised, but no fractures. And I saw her for like 6-8 months, and she lost her lawsuit against the oil tanker company that for damages, just because she had no objective signs. She had chronic kind of facial pain, headaches since then, which got better with treatment, but her quality of life really went down. So the perception, and that's a problem, the visibility, we are so used to in medicine relying on objective test, and orofacial pain is really a subjective phenomenon. Uh, so it's challenging at times. Okay. The pain, the other challenge is pain is dynamic. It can get better, it can get worse with number of interventions, with number of influences, and that influence could be environmental, it could be internal, meaning it could be sleep, it could be emotional trauma, psychologic, it could be autoimmune disorders, dysfunction. So it's important to kind of look at the big picture and then kind of come up with a plan. All right, we're ready for some questions.
Absolutely. Thank you so much for this great presentation. It was so thorough, and we're all so grateful, but we have a lot of questions, so I'm going to jump right into them. Okay. Is neuropathic facial pain related to complex regional pain syndrome?
That's a great question. So it's debatable if complex regional pain syndrome exists in the face head region. So the mechanism is neuropathic in nature for the most part for complex regional pain syndrome. This is a syndrome where people have typically, when somebody is in an accident, they injure their limbs, peripheral organs, and they have pain along with increased temperature. So there's a bunch of articles which talk about that it does exist in the face, jaw region. Again, the lack of objective testing for these conditions makes it really difficult to draw conclusions. So depending on who you talk to me, yes, it is a neuropathic pain syndrome, compared to some other person may not agree with it, and they may not be wrong in certain subset of patients.
Exactly, very subjective. From Neil, wants to know, can neuralgia result from shingles, and can tinnitus result as well from shingles?
Yes, so post-herpetic neuralgia is definitely a well understood disorder, pain syndrome. More, again, happens more in other areas of the body, but definitely has been reported in the face region as well. Now, tinnitus is, can it result from shingles, or can it be associated? I think it can be associated with viral infections. Again, very poorly understood. I have had patients where they got better, but I have had number of failures as well of patients who have tinnitus. And I always tell patients, if it gets better, it was related. If it doesn't, it was not. And that's not a good way of looking at things, but that's all we got so far.
Well, when you're gathering data, once you can cross things off, you can go to the next thing. So, okay. So from Kendall, you spoke about unnecessary dental procedures with TN. What type of procedures would typically be done? I know you mentioned a couple, but could you just review that quickly?
So a lot depends on what. So if a patient comes in, most of the times, endodontics is kind of the big one or the common one. Endodontics and extractions are the common one, where the X-ray looks unremarkable. We are suspecting a fracture in the tooth just because the pain is just so excruciating or so localized to the tooth, and it's not the tooth. So, and again, it depends on the individual who's treating the patient. So, if it does not, if it does not clearly look like odontogenic pathology, the radiograph is unremarkable, then it really should be held off. Wait if it swells up, or if it really patient develops fever. I know that's not a good way. We really, in this day and age, we don't wait for swelling to appear, but that may be the next best thing.
Thank you. Michelle wants to know, is trigeminal neuralgia and fibromyalgia related?
No. So trigeminal neuralgia typically happens in 50 years or older people. The pathophysiology of trigeminal neuralgia is, that's a different lecture by itself. We don't know why it happens, but we have Steve Chandwani was one of my mentors, and he used to always talk about trauma. The teeth are kind of undergo trauma multiple times in the lifetime. So eruption, shedding, eruption, and then dentistry kind of, they undergo a fair amount of dentistry over their lifetime. So you're talking about trauma to the same system at least 4 or 5 times, but most of the times 10, 20 times. So that predisposes the trigeminal system to kind of sensitization. So that was one thought which I think makes sense. The second thought, which has been often 50-60% of patients actually have vascular compression in the on the trigeminal nerve root within the brain. So and those patients respond quite well to microvascular decompression compared to fibromyalgia, where really it's a really poorly understood mechanism, pathophysiology, at least with regards to which areas of the brain are involved. When it comes to trigeminal neuralgia, it's really the brainstem and the cortex. That's kind of the main areas involved compared to fibromyalgia. It's so I don't think we're pretty sure they're not related.
Thank you so much for a very thorough answer. Ashley asked, so if there is no clear way to diagnose, how as a dentist do you determine what is the correct response to proceed with treatment?
So
Referring out to a different specialist. I'm sorry, I didn't mean to interrupt you. I apologize.
No, that's good. So I didn't say there's no clear way to diagnose. There's no clear objective test. So if you look at, I'm going to go back a few slides. So if a patient fits the clinical criteria, so this is the diagnosis, this is a clear way of diagnosis, trigeminal neuralgia. If they fit this criteria, they have trigeminal neuralgia. And if they fit this criteria, the bottom of your screen, they have neuropathic pain. So the unfortunate part is if they fit this criteria, it at times takes time. So a patient who has neuropathic pain, I treat GPR residents, and it takes 15-20 minutes compared to a patient who has odontogenic pain takes a minute. So you have to put in a little extra time to go over multiple systems to figure out what's going on in that individual. So it's just a matter of time and a little bit of practice. Orofacial pain, I feel, often at times, I don't have clear answers, but I tend to have clues as to what I don't know. So
that's perfect. Thank you so much, Doctor. The next question we have is about that first case study you did. And Viet wants to know, did you have an MRI of the TMJ?
So that patient, he actually had an MRI of his brain and sinuses. He was referred by his ENT, which overall was unremarkable. So he didn't have effusion in the joint. He has some arthritis generalized, but overall the MRI was unremarkable. I didn't have CT scan, and I didn't take X-rays also.
Perfect. Thank you. There are quite a few questions regarding zinc supplements. Gisette wants to know, which zinc supplements do you recommend? Marlene wants to know, how much zinc would you suggest to help with nerve pain? That people really want to know a little bit more about the zinc supplements, if you could expand on.
So I interchangeably use zinc picolinate, about 20 milligrams, alpha lipoic acid, 600 milligrams, and I'm happy to kind of share literature, email me, or I can actually have include that in these slides so we can kind of I have some sort of a cheat sheet that I use. I'm happy to share that. So when it comes to zinc, I typically use 20 milligrams of zinc picolinate. But I do tell patients to use it for like 6 weeks to give it time.
Okay, 20 milligrams per day?
Correct.
Perfect. Thank you. These questions were during your presentation for, I think it was a 70-something-year-old male. Hannah said, you mentioned topical anesthetic. Did you prescribe benzo 20% topical, or is that the same percentage as an over-the-counter?
It's an over-the-counter.
Okay, so something along the lines as Voltaren or something along
No, benzocan is kind of a dental anesthesia or oral for oral use. So
right.
If it's something which is okay for oral use, they can use it on the skin. The vice versa doesn't work. So Voltaren is not, at least the company instructions say not to use it even on the face. So although some of my patients use it with benefit.
We can't control, unfortunately, what they do once they get home.
And I've had some great results. So
good. Okay. So Hannah asked, are there any other drugs that can have the same result as gabapentin without the side effects? And Dorade also said, Can a general dentist prescribe gabapentin?
So general dentists can absolutely prescribe gabapentin. There's data to show that at 900 milligrams of gabapentin, the side effect profile is extremely low. The therapeutic dose of gabapentin is 1800 to 2400. That's where the short-term memory loss, the anticholinergic effects are much more troublesome. And of course, if it's a geriatric patient, you want to stay really low. I have had patients who are on like 600, 900 milligrams, much more commonly than 1800. So there's a number of medications. It's a long list. Just look up. There are guidelines on medications for trigeminal neuralgia. There's multiple papers talking about antiepileptics, oxcarbazepine, carbamazepine, gabapentin have kind of similar efficacy, and then lamotrigine, pregabalin are kind of second tier. Baclofen is also second tier, and then there's others, including antidepressants, amitriptyline, nortriptyline, desipramine. So anytime somebody comes in who has extremely poor sleep, I often go to a tricyclic antidepressant like desipramine or nortriptyline, which are kind of selective, so the side effect profile is lower, and they are great neuropathic pain medications, and they help sleep. Compared to somebody who's sleeping well, I may start them on antiepileptics.
Perfect, thank you. Aditha asked, what is the prognosis if the neuralgia is not treated right away? Say, for instance, after a year, if the patient did not have access to care?
I don't have a good answer to that one. I've had a number of patients where they actually didn't have treatment for 6, 8, 12 months, and I've had results. And then I've had a few patients where they were doing well for a number of time, and somehow they started kind of getting worse. I had a 37-year-old female who I've seen her for like 7 years. For the first 3 years, she did great on carbamazepine and botulinum toxin, and all of a sudden it just stopped working. And the last 2-3 years, we have a neurologist in, kind of a neurosurgeon, as well as myself. We've just struggled with her care. So we don't know kind of overall the course of the disease process. What we know is most trigeminal neuralgia patients tend to do well with medication/surgical intervention, especially classic trigeminal neuralgia. When it comes to neuropathic pain, definitely a lot more challenging. In my experience, it's a lot more challenging to manage neuropathic pain.
Thank you for that answer. Makor said, sometimes patients have a pain, I think they said in the chin, does transmit to temple area. I guess they're trying to determine if these can be connected.
Everything is connected. There's always a possibility of connections. So I always tell my residents, and I'll tell you, you're treating a person. Just because the pattern doesn't make sense doesn't mean it's not valid. So the patient's pain is real always. If it's pain in the chin, it could be neuropathic pain, it could be a referral pain from a muscle. I have a 32-year-old patient who I've been seeing for almost now 9 months. When he first came in, he had severe pressure in the middle of the face, around the nose, temples, and his bite was off. And 6 to 8 months of these symptoms, I saw him about 9 months ago. And with occlusal appliance and some nerve blocks, he's at a stage where his bite is better. I think it was just more a muscle, a temporary scenario that the bite was off. The bite is dynamic. Sometimes it's off for some reason. But even this symptoms of this severe pressure, it's like 70-80% better. And I've seen them about 4 times. So it's not as if we've done a lot of intervention. So it's at least with regards, I told Nathaniel, my patient, I was like, I still don't know why this happened. I know how to treat it, but I really don't know why this happened.
That's those idiopathics that are difficult to.
Most of them are idiopathic. They kind of, and I kind of really urge all of you to kind of, a response to treatment is not a diagnosis. If they respond to prednisone or if they respond to anti-epileptic, so response to anti-inflammatory or a steroid, corticosteroid doesn't mean it's inflammatory. A response to anti-epileptic does not mean it's neuropathic. Because there's a lot of overlap between mechanisms.
That is a very important thing to remember. Thank you for sharing that with us. Maria asked, does hemifacial spasm contribute to orofacial pain? She had both TN and HFS prior to MVD, and once the facial spasms stopped, so did her facial pain, which was mostly supraorbital and infraorbital.
I don't know. I really, I'll have to look up the literature on hemifacial spasms. I'll kind of, I'll have to get back on that. Sorry.
Is that something Maria should reach out to you?
Yes, happy to. Yeah, I can look it up. Yes, absolutely.
Oh, wonderful. Thank you. We just have a couple more questions. And you must be getting tired, but we appreciate.
No, I'm good. I'm good. I love questions.
These are great questions too. We have such great attendees tonight. Courtney asked, have you had success using lasers to treat trigeminal neuralgia?
I'm not aware. So I don't have laser in my office. I have a couple of friends who have lasers. I have a few physical therapists by my office who do utilize laser. I cannot say for trigeminal neuralgia, but definitely for chronic pain, chronic non-specific facial pain, as well as muscular pain, I've seen successes. Now, if you ask me, is that success? Can I put a number? I unfortunately cannot. Most of these treatments have efficacy of like 60%. And in pain medicine, 60 to 70% efficacy tends to be enough to qualify as a treatment modality. So anytime you utilize a treatment, if you making 6 out of 10 patients better, I think you should utilize that, especially something like laser, which is non-invasive. It's really worth trying.
And another question is, regarding medical histories, we take very complete medical histories and use such as the A1C or even thyroid blood work. Have you ever found a relationship with other systemic diseases and orofacial pain?
Yes, absolutely. It's a big one. So I practice in Connecticut, and I would say every month I have 3 to 4 patients who have Lyme disease. So I think autoimmune disorders are really huge in chronic pain, not necessarily just facial pain. And anytime I suspect autoimmune disorder, and even if they're different titers are normal, I often take a more conservative route rather than aggressive. So conservative with regards to medications, procedures, they just take a lot longer to get better. So, and I educate them that we have to be patient.
Thank you so much for all this. That was a lot of questions, and you answered them all so well and beautifully. And we're so grateful to you, Dr. Chandwani, for a wonderful presentation. So many people in the chat are saying, great presentation. Is it available? Are the slides available? We want to see it again.
Yes, I'm happy to share. We'll send a email to, should they send an email to me or Facial Pain Association? Both ways, I'm okay with it.
Okay, perfect.
I'm
I would
happy to share my slides.
Thank you so much. I would like to let all of our attendees know, though, that this webinar is being recorded and it will be made available to you as a self-study option. So you can listen to this webinar all over again and glean all that information that Dr. Chandwani was sharing with us. Again, thank you so very much for an incredible presentation. We're so grateful for you coming tonight and taking the time to share with us. We appreciate it. I'd like to
thank you all for being here.
Well, thank you. And thanks to our attendees as well for being here. I'd like to share the verification code. It has been shared in the chat and you can see it on the screen. But if you're listening into our webinar, the verification code for this course this evening is FPA2023. Now, if you don't have a CE Zoom account and you've signed in via a different way, just go and create that CE Zoom account and follow those verification code steps we've given you. There will be an email from FPA if you signed up through them that they will provide you with the steps and information. If you signed up through CE Zoom and you're having some problems verifying and getting your certificate, just reach out to help@cezoom.com and they will help you. Again, thank you so very much for coming, for your questions and for your participation in the chat. We love that you came and we all hope you have a wonderful evening. Good night.